The next presenter is Dr. Thirugnanam, and Madan is one of our consultant anesthetists and also has a special interest in pain management. He is the lead clinician for pain management at the University Hospital of Derby and Burton, and he's part of our MDT in pain management as well. So his contribution, and as well as the entire pain team's contribution, is brilliant to the purpose of management of women. So I'm just gonna start sharing.
Good afternoon, everyone. My name is Dr. Madan Thirugnanam. I'm one of the anesthetic pain consultants from the Royal Derby Hospital. I'm here to talk on the endometriosis pain mechanisms and the principles of management. And I thank the organizers from the Derby Endometriosis Center as well as the Delta team for inviting me to give a talk on this second Delta Endometriosis Symposium at Derby. Without further ado, I'll go on to my topic. And the overview of my topic is going to involve a gentle introduction followed by the health, social, and economic issues of people with chronic pelvic pain, briefly touching on the neurophysiology and neuropsychology of these patients, and running through management guidelines of these chronic pelvic pains, and also looking into the role of the multidisciplinary pain clinics, and looking finally at the general consensus after looking at the analgesics. The recommendations are going to be from various Canadian, American, and European bodies. Um, and we all know that endometriosis is a hormone-dependent progressive inflammatory disorder when the endometrial tissue is formed outside of the uterine cavity, forming various issues like chronic pain, infertility, organ dysfunction, dyspareunia, and so on. Chronic pelvic pain causes a huge impact on the health, social, and economic implications on the society, causing decreased quality of life due to severe pain or mental health issue due to infertility, dyspareunia, and so on. This could be because of the delayed diagnosis causing productivity loss. And the delayed diagnosis can be typical between 5 to 10 years. And that's with the patients moving from one specialty to the other, having various consultations, interventions, and investigations, and so on. Endometriosis roughly affects about 10%, which equates about 190 million of reproductive age women and girls globally. That's a huge, staggering figure, really. And various other issues like dyspareunia decreases the standard of sexual and reproductive health, decreasing the quality of life and the overall physical and mental well-being of this women. If you take chronic pelvic pain as an entity, there is a myriad of causes, including gynecological causes, urological causes, gastrointestinal, musculoskeletal, and psychological causes, out of which endometriosis is one of the common causes within the gynecological issues. With endometriosis being one of the common causes of chronic pelvic pain, which is a heterogeneous, multifaceted condition.
Sorry, we're trying to
Having
make it
both
full
peripheral
screen.
and central generators of pain from a variety of abdominal pelvic organs with specified neurobiology and neuropsychology should be guiding the management with several pain generators. And the treatment of the chronic pelvic pain should be multimodal pharmacological treatment strategies, including various medications and hormone suppressants, antidepressants, membrane stabilizers, and so on. And the treatment could also involve a combination of medication, behavioral changes, and obviously the surgical techniques as well. If we closely look into the pain mechanisms for endometriosis, there is a variety of complex possible mechanisms. And we all know that the endometriosis is the presence of endometrial tissue outside the uterine cavity, but that these tissues can become inflamed and release inflammatory mediators like cytokines and prostaglandins, which in turn sensitize the nerve endings and contribute to the pain. In addition to that, the endometriotic lesions can induce the growth of nerves, essentially a neurogenesis, and these nerves can become hypersensitive and more responsive to pain signals, leading on to an increased pain perception. And the neurotransmitters like substance P and nerve growth factor play a role in these nerve sensitization process. We all know from the multiple surgical procedures or even otherwise, the endometriotic tissue can itself cause formation of additions of scar tissues, which can bind various internal organs and cause severe visceral pain, leading to tension, pulling, distortion of the surrounding structures, and so on. These contributes to the pain severely. Number four, the pelvic tension could be secondary to increased muscle tension in the pelvic floor and surrounding muscle, causing further pain and discomfort. If you look into the nociceptive pain or the lesions causing nociception or the pain from the specialized nerve endings, which is the nociceptors that detect the pain, and this could be from peritoneum, ovaries, or various other organs which are affected. And hormones, especially estrogen, play an important role in the endometriosis related pain, which promotes the growth and maintenance of the endometriotic lesions causing pain. So, hormonal fluctuations, obviously, during the menstrual cycle can affect the pain intensity greatly. This is another fascinating slide about the pain mechanistic factors on endometriosis. If you look into the peripheral stimuli, we looked into the endometriotic deposits causing pelvic inflammation and neurogenesis. But there's also the central sensitization factors like the upregulation of the periaqueductal gray, which is essentially an important uh, factor in the descending pain pathway. Whereas the increased ascending pain pathway or a barrage of uncontrolled noxious stimulus through the spinothalamic tract can also worsen the pain experience in these patients. The psychological cognitive state due to the impact of the dyspareunia, the infertility, depression, and anxiety causing catastrophization, as we call it as yellow flags with various socioeconomic factors involved, makes the disease process and the treatment modalities very difficult to treat. Um, there's also various previous surgical procedures in an attempt to cure the disease causes more pelvic adhesions, as we discussed about it. And if you look into the immune system, the decrease in the clearance of the retrograde menstruation or a decrease in the hypothalamic pituitary axis dysfunction causing a reduction of the cortisol secretions can all worsen the quality of life by increasing the pain. And the inflammation, there's increased peripheral inflammatory mediators in various abdominal pelvic organs, and inflammation within the spinal microglia as well. So just the supraspinal and the spinal levels, there are various different modulators in these patients. This is a slide showing the pain pathway, which we discussed in the previous slide. Essentially, nociceptive input is processed and modulated by ascending and descending pathway in the central nervous system. So many factors influence how the brain processes the pain. So the experience is quite individualized. But the stimuli traveling from the spinal cord through the spinal cord's dorsal roots, which contain the nuclei of the sensory nerves from both somatic as well as the visceral components, um, convey the stimuli to the spinothalamic tract of the spinal cord, through the important synapse governed by a complex array of neurotransmitters. So that's essentially the ascending pathway and the descending pathway. So barrage of noxious stimulus through the ascending pathway and decrease a descending inhibition, all can make the pain experience quite worse. So our pain treatment will be targeted at decreasing the noxious stimulus in the ascending pathway and promoting the descending inhibition in the descending pathway will be the ideology as if we talk about the neurophysiology as such. Um, this is an interesting slide of pictures of functional MRI on patients with chronic pelvic pain. There are postulates of volumetric changes in the brain in patients with chronic pain condition, not just chronic pelvic pain. So if you can look into the slides on the left, these are pictures of patients with chronic pelvic pain. The one in the top is patients with endometriosis, whereas the one in the bottom on the left is patients without endometriosis. As you can see, there's this decreased regional gray matter in patients with or without endometriosis, but experiencing chronic pelvic pain. Whereas if you look on the right-hand side, these are patients with documented endometriosis, but do not experience any chronic pelvic pain. But these patients do not have any regional uh, gray matter reduction at all. And I mean, the why are these alterations in pain volume there? I mean, we do not know the complete answer to this, but this could be because of the neurotoxic effect of repeated episodes of pain leading to the neuronal atrophy or death, and an effect of altered metabolic activity or neurotransmitter concentration, and also secondary to the neurotoxic effects of various drugs which we use, maybe secondary to the neurodegeneration of the pain-related inactivity and an effect related to the psychological aspects of anxiety and depression can also cause all these regional brain volume reduction, I suppose. Um, as I said, it happens in people with other chronic pain conditions like fibromyalgia, chronic low back pain, chronic headaches, various a myriad of conditions can be implicated on these things. Um, if you again look into the classification of the mechanisms of pain, of the causes of the chronic pelvic pain, it's broadly classified into a nociceptive pain and neuropathic pain. Amidst nociceptive pain, you again have visceral and the somatic pain, out of which the gynecological and non-gynecological causes. Endometriosis is one of the gynecological causes in addition to the other causes like PID and ovarian remnant syndrome and pelvic adhesions and so on. Um, but if we look into the endometriosis pain management review as a whole, there's not been any study directly compared between medical or surgical management. There's no one treatment modality recommended superior to the other. Patients may initially be given a medical diagnosis and treated with simple painkillers in addition to the hormone suppressant treatments. But surgical management eventually follows, which includes excision or ablation of these lesions and progressing to major surgery. If we look into the evidence of the management of the chronic pelvic pain, there are various modalities, and I just looked into each and every modality, the evidences behind that. So if you look into the multidisciplinary approach, there is a systematic review in the Journal of Pain Research, highlighting the effectiveness of a multidisciplinary team with gynecologist, pain specialist, physiotherapist, and psychologist. Whereas if you look into the pelvic floor physical therapy, there's an RCT published in the American Journal of Obs and Gynecology showing that the pelvic floor physiotherapy, including the manual therapy exercises and relaxation, have significantly reduced the pain and improved pelvic floor muscle function in women with chronic pelvic pain. Further, if you look into the psychological treatment modalities like CBT or ACT, which is acceptance and commitment therapy, a systematic review and meta-analysis published in the Journal of Psychosomatic Obstetrics and Gynecology. Sorry, I didn't even know that a journal existed in this name beforehand. So, anyways, a meta-analysis showed that the CBT interventions for chronic pelvic pain led to significant reduction in pain intensity and psychological distress, which in turn improved the physical functioning of these patients. If you look further into the Cochrane database of systematic reviews, there are several reviews on the effectiveness of hormonal therapies in managing chronic pelvic pain due to conditions like endometriosis. They found that the combined OCPs, progestins, GnRH analogs can provide pain relief and improve symptoms for several women. Um, Looking into the surgical interventions, systematic review, meta-analysis published in the Journal of Minimally Invasive Gynecology demonstrated that the laparoscopic excision of endometriosis lesions can significantly reduce pain and improve the quality of women. Um, Whereas the evidence for complementary and alternative therapy is pretty sketchy, but nevertheless, there are some studies published anyways. Um, the systematic review published in Pain Research and Treatment highlighted the potential benefits of psychological interventions such as mindfulness based stress reduction, ACTs in pain severity, and improve physiological well being and the psychological well being of these individuals with chronic pelvic pain. With those all of the evidences behind us, what is the role of the pain clinic in managing these women? Essentially, we have a multidisciplinary pain team and approach the patient with a holistic view. It's just not to manage the pain itself, but also various other factors like anxiety, depression, quality of sleep, which will include medications, occasionally injections, and other mindfulness-based treatment and physical exercises and various other treatments. With those, so our MDT comprises evidences behind consultants, both pain consultants, and what is the role of the pain clinic in managing this frequent? Essentially, we have a meetings with pain team, our gynecology colleagues, the patient with along with a clinical nurse specialist, physiotherapist. It's just not psychologist manage the pain itself, engaging in this MDT discussions, other factors like anxiety, especially complex patient sleep, which when we medications, occasionally injections, and these other patients, we mindfulness-based treatment and physical exercises, patients trying to understand what the pain generators are, and how does the we look into
Sorry.
how these patients perceive their pain along with their life experiences.
It's fine now.
Having looked into the history and examination of these patients, the first line medical treatments for chronic pelvic pain is essentially to create a hypoestrogenic state, which is treatment selected essentially by you folks, the gynecology colleagues, depending upon the patient preferences, side effect profile, and also efficacy of the medications in certain conditions. And I'll leave that with the experts, and our intervention essentially comes in instituting either simple analgesics as needed, and also including non-steroidals. Opioids are not advised usually, and we use atypical analgesics quite frequently. I'll come to that. Opioids are strongly discouraged in any chronic pain condition, be it chronic pelvic pain, fibromyalgia, or any other functional disorder. So we often deprescribe the medication, and there's no data essentially supporting the use of opioids in any pelvic pain or any chronic pain condition, really. If you look into the role of antidepressants, they have a significant role in pain sensitivity and maintenance of these chronic pain conditions. So you have tricyclic antidepressants, which is amitriptyline, or the secondary amines, which is nortriptyline, and SNRIs, which is serotonin norepinephrine reuptake inhibitors, like duloxetine. What do they do? I mean, essentially, there is a dysfunction of the descending. If you look into the role of antidepressants, they have a significant role in pain sensitivity and maintenance of these chronic pain conditions. So you have tricyclic antidepressants, which is amitriptyline, or the secondary amines, which is nortriptyline, and SNRIs, which is serotonin norepinephrine reuptake inhibitors, like duloxetine. What do they do? I mean, essentially, there is a dysfunction of the descending pain modulatory system, which is thought to play an important role in the pain sensitivity. And there is increased availability of noradrenaline or serotonin, the descending pain modulatory pathways, appears to decrease the pain sensitivity, and hence the reuptake inhibitors and the tricyclic antidepressants, which act in the similar way, are much more helpful in as a starting point, in addition to the. If you look into the membrane stabilizers like calcium or sodium channel blockers, the gabapentinoids are relatively frequently used with or without the use of antidepressants mentioned previously. They act by decreasing the reuptake of glutamate, norepinephrine, or substance P. They function by reducing the hyperexcitability of the nerves, both peripherally and centrally, whereas the sodium channel blockers are less frequently used in chronic pelvic pain, and probably more so useful in atypical facial pain conditions. The role of NMDA receptor blockers have been discussed, but the evidence base is yet to be determined. So I'll leave that well alone for the time being. If you look into a variety of interventions compared across pain, infertility, or pain and infertility, and also symptom control, most of the medications, there's no network meta-analysis data or substantiating the use. So, having said all those things in the past, any of these medications don't control the pain alone. And obviously, they've got no effect on fertility. Um, and when we compare both, they're not brilliant, obviously, but symptom control is relatively better. But that goes to say that the surgical treatments, as well as the hormonal treatments, are much more useful in pain and infertility treatment, in addition to the symptom control. We briefly touched on pelvic floor, physical therapy, CBT, neuromodulation. There's also various dietary strategies, improved sleep hygiene, lifestyle modification, which can be useful in these patients with psychological morbidity. Having talked about the holistic therapy for these patients, pain management programs are an excellent way to institute this. People who have chronic pain conditions can be grouped together and have sessions delivered by a multidisciplinary team, including nurse specialists, consultants, physiotherapists, psychologists, and sometimes even social prescribers. So, what this does is empower the patient to talk about their problems and get educated on various exercises, self-management therapies, and they're able to generally progress as weeks go by. So it could be anything between 6 to 10 weeks on a weekly session basis. We are trying to institute a specialty specific pain management program for our chronic pelvic pain. Um, uh, Hopefully, that will be instituted some point soon. If the patients can't devote the time or they can't handle the groups, then there are also self management sessions given on a one to one basis by our clinical nurse specialist on an occasional basis. There are a number of relaxation techniques which is being taught to the patients, which helps them combat with the sleep and pain issues, and also to alleviate the stress. Um, it could be in the form of meditation, biofeedback, or visualization techniques, and that are quite helpful to our patients, especially in a chronic pain management rather than just an acute flare-up situation. Having discussed about a plethora of conservative management principles of the chronic pelvic pain patients, the various recommendations, which essentially come from American and Canadian bodies, which suggest understanding the needs of these women through developing a rapport with these patients. And obviously, that takes time, including general clinical assessment, uh, which involves looking at the pain levels and trying to ascertain the myofascial pain triggers, instituting medications and optimal surgical procedures on appropriate patients, and principles of opioid management, as we discussed, and also maybe instituting investigations on patients when needed. When these patients undergo surgery, the extent of the disease is observed and documented appropriately. And also looking into the multidisciplinary team like physiotherapist or psychologist will be useful. But the way to go about it will be to increased onus on training and also future research, and also maybe to create a multidisciplinary team will be helpful going forward for these patients. Um, that's the end of my slides, and I will take questions in the appropriate session. I thank you